Thank you, team, for inviting me. It is indeed an honor to be here this morning. And yes, challenges are there in life, and so are there in the job we do. And from the simple to the complex. When we speak of challenges in a clinical chemistry lab nowadays, our first thought processes are hill. There is much more than what we see in the standardized hill of nowadays. It has always been there, and we have always been working on it, but maybe more processed and more protocol in the last couple of years. Now, what are the challenges that we face in a laboratory? As we all know, we express the work in the laboratory for easing our thought processes as pre-analytical, analytical, and post-analytical. Now, what can complicate or be a challenge in the lab? The very start of that, we are going to receive a sample. The timing of the sample, so specific as in hormones such as cortisol, which have reference ranges at 2 particular times. Can we take hormones 24/7? No, we have to understand that there will be diurnal variations, which we should understand to explain not only to the doctor, but also to the patient, which is sometimes a very hard job. Now, what are the containers that we use? Yes, we have come a long way over the past 10, 15 years that we know what color caps we use for what. But still, you will see that there are a lot of deviations, lot of errors, not only from the lab of phlebotomy staff, but also from the nursing station. And that is very important, or the source where the sample is collected. We have a lot of doctor clinics which know very little about how to collect what and when. And we also have a lot of courier services or standalone reference labs that we send our samples to. But are we all on the same page? Many a time, no, especially when it is a question of smaller towns or rural areas. And how do they transport or store these samples? So our issues start from this pre-analytical timing of these incidents. Then presuming that at least 80% of these things are in place, and there may be minor errors which may not affect the final analysis or reporting, we go to what we look after. We look after mostly the analytical processes, and literature always states over the past 10, 15 years that analytical errors are very minimal. But do we have or understand a listed challenge of what all we can face in an analytical phase? We take water for granted, and it is all tested prior to NaBl or NaBH. The water source is very important. It is something that people overlook either when they set up a lab or in hospital labs where the management is not willing to spend a lot of money to see that you get good water. In good corporate and well-established labs, yes, RO water and systems that purify this water are available. So our issues start from water. So imagine in a small place, a rural area where we have a lab. We are doing hormones even in those labs nowadays, but what is the water source? And especially in a rainy season, how do we approach this problem? Even in our big cities, when there is a cyclonic threat or a tremendous downpour, and you see the filters that are there in your water systems, they are just more than brown mud. So one has to be very careful, especially after these seasons. So water is absolutely a challenge to all of us. Instrument-related assays. Instruments nowadays are robust. All companies are more or less on the same page, high level, high efficiency. And it is the person who stands with the machine has to understand that how the machine works and what inputs have to be put in to get out a good output. So instrument-related assays by themselves in terms of calibrations, in terms of IQC, etc., are itself a challenge. Manual assays. Manual assays are far and few in well-established labs, but I should say that manual assays and small instrumentation is a necessity in many labs, especially when we speak of Hill, to monitor certain assays. Now, I, for one, maybe as an old timer in my many years of experience and age, would say that ideally every lab, however sophisticated, should have a spectrophotometer isolated from the main automated systems to help us in many a condition of Hill. What is routine chemistry and how do we approach it? Routine chemistry is chemistry. Yes, those tests that are common, and we usually take it for granted that we can never go wrong in this. But if you monitor these tests in periods not only of the Hill that we speak of, there can be many challenges, many challenges. Lot to lot variation is a common one. And also the calibrator or the deterioration of the calibrator and controls is a challenge. So there has to be a dedicated staff or personnel who look after these things. Hormones are a problem by themselves. We have so many instruments and we feel whatever we put in and what comes out is absolutely correct. No, if we sit and ponder over our results along with the clinical history, then only we understand in how many processes we have gaps. Special proteins, which I'll come to later, special in the sense that they are not done commonly. They may not be done on the same automated system that one has or a platform. There are different, various sophisticated instruments also which do these proteins and which have their own problems. And of course, in understanding and analyzing all these issues, we have to understand quality management, which was dealt with so stupendously by Dr. Asha Vaid yesterday. Now, coming to the post-analytical, yes, we have a report, we have units, but what we are missing is interpretative comments. It is very essential as we move on in life, in the lab, with so many other advantages. Something that we lack is nowadays interpretative comments. It makes it easier because it gives us a thought process for reflex testing, and it also makes us communicate. And let me tell you from my vast experience, communicating with the clinician, communicating with the other divisions of the lab makes a perfect report. And when we are comparing reports, please check the units. Many a time the clinicians come and say, this is your report and that is that report. And then you say, doctor, please have a look at the units, and then the whole problem is solved. These issues which I have just mentioned seem routine and seem passable. No, if we actually sit at the desk and then think it over, we have enough problems even before we start reporting. Patient preparation. Is this a challenge? Of course it is. Starting from the common glucose tolerance test that we do. Now, the concept that the glucose that we were using at 75 grams has to be altered with the specific measurement of monohydroglucose and the weight changes. Are we prepared for this? If you're working in a hospital lab or a tertiary care or a referral lab where endocrinologists do a lot of challenge tests in fertility, along with growth of kids, obesity, etc., these patient preparations are absolutely necessary. It is a different ball game. It is not that a patient walks into the lab, you draw a sample and you do the test. No, the timing is important. What drug the patient was given, what are the side effects? Can you keep the individual in the lab and do the test? Or there has to be a close clinical monitoring, like if they give clonidine, etc. Or if you're doing a renal tubular acidosis test for an RTA, then you have to be very careful of the bicarbonate, the acidification of the urine, etc. These are not simple. These are actually not simple. Clinical history. In a hospital lab, yes, clinical history is more attainable than what would be in a standalone or a referral lab. But let me tell you, this is one of the main aspects that we have a challenge in. What is the medication the individual is getting? You take a simple prothrombin time. All of us use coagulometers. All of us sign out prothrombin time test. How many times do we ask if the patient is on an anticoagulant? And if so, what type of anticoagulant? Is it just an oral anticoagulant, or is it the newer type of antiplatelet drugs? This can be a problem. Patient will come to us taking the newer type of antiplatelets prescribed by a cardiologist, and the cardiologist or the resident that signs out, do PT. PT does not answer this test. And when you do a PT, you can get a very false report, either elevated or very low, and then there is a lot of problem. So we have to be very careful in taking history. Even if it is an outpatient, history taking, especially in certain tests, is absolutely necessary. If a patient is also coming for some tests, especially like APLA or even PT test, ask the patient, have you ever been on Ayurvedic medication in the recent past? Are you on homeopathy at the moment? Is there any other type of alternative medicine you're taking? It is absolutely essential. We are only thinking of challenges in relation to our instrumentation. We are not thinking of challenges prior to us taking the sample into the instrument. Simple, prolonged tourniquet application. Elderly cardiac patients, especially where potassium drugs are on, and potassium is an absolutely essential parameter, do not tie a tourniquet. If he's an old patient who you know, and if the tourniquet is absolutely necessary, you please see that it is of a short duration, not tying the tourniquet and then talking to somebody and then doing it. These are not done. And you will see elevated potassiums. The doctor is apprehensive what to do. Should he correct it? Then we have to say, no, send us a repeat sample. It's okay in a hospital lab, but how does it work in a smaller lab? How does it work in a standalone lab? How does it work if one does not have understanding of a tourniquet application? Yet another problem, a challenge, we have not yet reached instruments. We have not yet reached the lab source. We are still in the preliminary collection of samples. Urinary collection, urinary VMA, urinary metanephrine, urinary HIA. These have different preservatives. Urinary protein. Can we do a random sample, or should we take a 24-hour sample? In which conditions are random samples accepted? In which conditions would it be advisable to do a 24-hour sample? These are challenges. And these challenges have to come from the top brass of the laboratory. It has to be clearly understood. And now you know that we document everything, but still there will be gaps. It is a daily affair that we have to look into. A wrong preservative into a wrong parameter to be assayed can cause havoc. How do you store these samples? You want to do a porphobilinogen or an ALA in the urine. Can you collect it in an ordinary container or jar that you usually give? No, it has to be amber colored. If you do not have an amber colored bottle, you're using your regular white glass colored bottle, then you please see that you put a brown paper on it or do something, or a black paper, that it doesn't have direct sunlight. Are these small challenges? They are greater challenges than what the instrument actually causes us. Timing specific as hormones, prolactin. Fasting sample is what we say. And we usually say that these are pulsatile hormones. So in pulsatile hormones, the usual practice and the teaching process, what we have been taught and what we teach is you take 3 samples with a gap of 15 minutes each, cool it, and then do it. But many endocrinologists and physicians will throw you a paper saying, now this is the latest endocrinology paper, which says 1 sample is enough. Then you have to sit and discuss and do what you think and stick to it. There are certain doctors which believe that whatever the lab says is the Bible because they know more than them, which is sometimes very true. So we stick to that, but somewhere we have to work across with them. Otherwise it is very difficult. Drug assays is another ball game. Drug assays like cyclosporin, tacrolimus, digoxin, vancomycin are not easy to do. And since they are not on a routine basis, following and monitoring the quality controls, etc., is a very tough job. You have to monitor the medication they are getting, temperature, storage, power supply. When we set up labs, we are very persistent that we have an UPS system. Now comes the bigger problem, pneumatic tube system. Everybody thinks a lab is sophisticated if they have a pneumatic tube system, and not up to the ideal way if they do not have one. Let me tell you, pneumatic tube system is extremely good, but it is sensitive to extreme changes to temperature and vibration. There are certain samples like ABG or coagulation which cannot be sent to this. Sometimes parameters like ammonia or lactate can also change. So each lab, according to the speed of their systems and how they do it, has to set up a guideline for the pneumatic tube system.
Hello.
Yes. Now we come a little more into the lab. So when we are in the lab, what is our first problem? As I mentioned, water. Do we monitor water? And before the time of NABL and NABH, the administrators will come around and say, okay, we are sending the water. Do we do it on a regular basis? Do we do it at periodic intervals? And there are different types of impurity that we have to live with. They are ions, they are particulates, they are organic matter and bacteria and bacterial products. These in some way or the other are going to interfere with the analyzer performance. So understanding them and understanding what actually we are doing when we send water for testing is important. Some of the bacteria, like one of the species of Aspergillus, Pseudomonas, gives out a fluorescence color which can interfere with assays. Ions can change how we look at electrolytes. Particulates can clog the tubings. So water testing is important, and that is where our first performance of using sophisticated analyzers lie, which we tend to neglect. Now there are assays, routine chemistry, hormones, drug assays, acid-base analysis, fluids, critical parameters. Each set of these assays provide different challenges. Now, when we speak of chemistry, we speak of the hill, which I'll get into. When we speak of drug assays, as I mentioned, the dosage, whether it is a peak sample or a trough sample, when was it given, compared to the monitoring or a delta check of the previous dose, these are absolutely essential. And let me tell you, the clinician finds confidence in our reports when we ask questions, when we are constantly interacting with them. Acid-base analysis is very critical, and we know it much more during the past 1 year, how critical it can be. Now, acid-base analysis is something that one has to master in collecting a sample and the transport. There is a lot of debate how this can be transported, which I will come into. What I'm trying to tell you in this slide is, it is not routine chemistry which can just be pushed aside. It is not only the application of Hill to our chemistry parameters. It is all these variables of fluids, acid-based drugs, which are challenges by themselves. That's why we should dedicate our senior techs to look into this, or the senior monitors, supervisors, whatever the designation may be. Each one has a role to play, starting from check of water. And as we go into this interferences, we also have overcome, we presume, the IQC and the EQUAS, which answer some of the interferences that we are going to deal with. Now, this is something the whole world of laboratory medicine is talking about. Was it not there 40 years back? Was it not there 20 years back? Didn't we overcome these problems? Yes, we did. Maybe our understanding was less, and we didn't have many protocoled ways of looking at it. What does it mean? Hemolysis, icterus, lipemia. These are terms which we are very common with. It is an issue of specimen integrity issue. How does the specimen look? Now, when we have our vacutainers, unless we centrifuge a sample, we sometimes do not know if it is lysed. And it is so routinely done that centrifuge tube goes into the instrument without even a naked eye checking. Not only with the juniors, it happens with all of us, me included. Now, when we are not looking at this, or we are having a lipemic sample, when do we tell the technician that this is a lipemic sample, you cannot run it directly? Unless we have guidelines, which over the past couple of years, the various auto-analyzer platforms or the quality companies are telling us how to do these things. So it is a specimen integrity issue. It helps in interference variation. Would you discard a sample of hemolysis, which is 1 or 2 plus for potassium? Would you process for potassium when it is 4 plus? How would you treat a lipemic sample? Would you treat a lipemic sample of 400 TGL the same way that you would treat 1,000 milligram of TGL? Would you do the electrolytes in both these type of samples? So the hemolysis, icterus, lipemic platforms, which are teaching us more and more that each lab has to standardize what their cutoffs are and decide what tool they would use to process the sample or not. The variations are different for hemolysis and icterus. It is a spectral interference. I won't go into the basics. And for lipemia, it is a light scattering procedure. So the different type of tests that we can have problems with lie on the mode of measurement that one is doing. Now, how do you deal with icteric specimens? I've taken this from the AACC. You have a cutoff limit by your preliminary experiments which you have done in the lab. And then you go through this. You go through, is it yes or no? Is dilution a possibility? Do you have to determine the parameter by an alternative methodology, like they have quoted creatinine? You are doing a Jaffe reaction, but you feel that it is not answering what the icteric sample does. And therefore, would you do an enzymatic method? How many of us in the labs can afford 2-3 methods? I hardly think 5 to 10% in our country. And that also may be very high. So how do we look at this? So that is the reason that these various platforms of analyzers and the quality companies are telling us how to look at it by doing the dilutions on a patient sample of variable icteric samples or hemolyzed samples or lipemic samples, and to arrive at a definitive conclusion in your lab. Is it true that you should have a different type of a smaller system like a spectrophotometer or a semi-automated system where you can use a blank? I would humbly like to say that many times we use blank samples. And many of my colleagues in the city, you have a semi-automated in your lab, you have a spectrophotometer in the lab, maybe it is old school of thought, but these instruments do help us overcome many problems. Blanking does not help all the time, I accept, but blanking on these simple instruments has helped us many a deal to come to the nearer to the reading nearer to what it should be. It may not be 100% perfect, but in the environment that we work, whatever we are able to do, we should do. I always promote that even in the most sophisticated lab, if you do not have a research lab which has the feasibility of a spectrophotometer or a semi-automated for simpler tests, all clinical labs, however sophisticated, this is my school of thought, this is my understanding over the years, that we should have a spectrophotometer and a semi-automated machine, which in a situation, maybe in the night or in a very critical situation, would help us in many ways when the sample is ectric or lipemic. Now, the Abbott company has a clinical chemistry learning guide series, which is very old, but it gives you the typical methodology of how to go about this and how it would interfere with your test. The various wavelengths that you should do and where you can do it, not necessarily on the most sophisticated analyzer that we automated analyzers that we have. Do it simple on your semi-automated. Get an idea of what your interference would be. Get an idea of how much of the 1 plus 2 plus 3 plus that is expressed. You can do certain parameters, and where you cannot do certain parameters, as potassium I have told you. Now, ammonia. This is a critical test. The way you collect the sample, the way you transport the sample, and of course the processing. Now, one of the guidelines of accreditation, not only in our country, you cannot send ammonia to another lab. Yes, unless the time is very specific and you are sending it in the most appropriate way within a period of half an hour to 1 hour, is what some of the literature says. But is hemolytic sample overrated in ammonia? There is a very good article where I have mentioned here from the Archives of Pathological Lab Medicine, which says hemolysis does not actually interfere with the ammonia assay that we do, provided that they have given a lot of 1, 2, 3, 4, that you are using that particular methodology and you are doing it within a specific time. So to reject an ammonia, which is slightly hemolytic, is absolutely not necessary. If the hemolysis that you have the Hill index on is there, you can go ahead and do it. Acid-base analysis, which is yet another problem for our labs. First, the interpretative competency should be there, because once we do it, there are particular calculations and particular parameters which tell us that this run is wrong. This is another 2 hours lecture by itself. I won't go into that. But if you have an experience or the authority to sign out an acid-base ABG report, the parameters on the report will tell you whether the run was correct or not. Now, the main point in me bringing acid-base analysis to this discussion is there is a lot of debate on how we transport. What is the temperature and what is the turnaround time? Each company has a different view. Each lab has a different view. Each expert has a different view. So if you tend to read a lot of literature, it is confusing, but the general baseline is that you can send it on ice. There is a very strong debate that you cannot send this sample on ice because the ice changes the leukocyte release, etc., and therefore the oxygen comes down. So if you are able to send it in a time process of say 10 to 15 minutes, wait for a report within 6 minutes of what you have drawn, then you can do it even on ice or without ice. But this is a debatable topic, and each laboratory has to find out for its sample for themselves from where the sample is coming. Are they able to give a perfect turnaround time, or is it just kept like that? Similarly, in ammonia, how you transport the sample, the textbooks say flush of ice, but we send it on an ice pack. Is it the same? Do we actually cool the tube before we draw the sample? Is your nursing staff trained or your residents trained so perfectly that they follow all this? This is something that brings the lab into saying that we have to discuss with the clinicians how we overcome these difficulties. Because for the clinician, your report is wrong, clinically it is not correlating, etc., etc. But unless the lab pulls up its socks and says, I know what I am doing, I will talk to the clinician and see that we both are on the same page, these problems unnecessarily exist for us, for the patient, and for the physician who is treating the individual. Now, lipemia. We all understand lipemia, and we all understand what we can do. The maximum most of us in the labs can do is centrifuge at a high speed for a specific period of time other than what we do the routine samples. Or we can dilute, which is more common and easy, or we can buy a lipid clearing agent and do it. If we do these three things, usually we are able to report the samples in a lipemia. The problem still exists for electrolytes. When one has a lipemic sample, be very cautious when you have hyponatremia or hyponatremia. It is a pseudo reading, and if you're fortunate enough to have another platform where you are using a direct ISC, go ahead and do the direct ISC. If you have a chemistry analyzer, plus you have an ABG, it is the ideal way to compare where we are going wrong. And over a period of time, we will have a lipemic index that we can resort to when we know what level of lipidology that we are dealing with, especially the TGLs, etc. So, and since the electrolytes are so critical, I'm just emphasizing this. Each lab, we just cannot go by all what other labs have done. Each lab's platform is different. Each lab's measuring capacity is different. The measurable range, the intensity, etc., etc. So it is always better to have your own lab. Yes, literature is our guideline. Our peers are our guidelines. We can always approach them. We are always not perfect. We don't know everything. By talking to each other, we can always come to a conclusion and help each other. In the final run, we are helping the patient. Hormones. This, I think everybody has problems. We have antibodies which cross-react. A simple assay which we take for granted like TSH. Yes, lot of queries. That lab gave me this morning, you gave me, evening you gave me this. So I think we have to understand what we are dealing with. I have been in a soup once where an elderly patient, a doctor, retired, a family friend, says, I come to your lab because you are there. And on the dialysis bed, the TSH was not what he usually got. Then we had to check the lot. What happened? We tested it in 3-4 labs, 2-3 labs agreed with us, 2-3 labs did not agree with us. So we had to do a lot of work and I had to apologize. Sir, I am sorry. These are some antibodies interference in our particular lot, which we dealt with the company. Now, these are things when a patient comes back to us, don't say that my lab is just correct. Just be pleasant, be empathic, and just try to see where we are going wrong. We have different platforms all over the cities and towns where we can reach it. And this is no competition among them or among us. It is only one part to give the patient the right treatment. Thyroglobulin, a specific marker in monitoring total thyroid. I'm just taking few examples of hormones. Now, most of these patients have antibodies which can interfere with the thyroglobulin immunoassay when the patient is monitored. This has to be kept in mind. Economically, can we do thyroglobulin antibodies every time we are monitoring this? No. You come to a conclusion with the clinician. When do you think I should look for antibodies in this particular sample when I'm monitoring these individuals? These individuals are our regular patients. These individuals come to us year after year. So it is our responsibility to make a step forward, go to the clinician, read and see what best we can do. We may have an instrument which does not solve our solution. What should I say? A lot of empathy Be big-hearted. Go to the lab, send the sample to the lab, which can give you the best report. Each lab is not perfect, 100%. Each lab is not Six Sigma. No lab is Six Sigma. Believe me, whether it's Sigma Matrix, Sigma, whatever rating you may say, we all have pitfalls. We all have gaps. Our responsibility is to identify the gap and see what best we can do. There is no humility if we do not look at a lab which can perform better than us in a particular way. And I think that is where we tend to learn and become good laboratory professionals or doctors. Now, this is something I don't want to go into in detail because everybody is familiar with this biotin issues, and it looks as though we are pointing fingers at particular companies, and all of those who you deal with this assays, I think all of you know what I'm talking about. Otherwise, it looks as though we are just pointing a finger at a particular company. At one stage, every company just shunned that company and said, no, they have this problem, they have this problem, they have this problem, which I thought was in very bad taste. This is my personal opinion. All companies work with an aim to do good for the patient. And we, as their Wendy's, buy these kits to do best for the patient. But somewhere it may go wrong, and we have to be magnanimous, either they or us, to accept that there is a gap and try to correct it and not shun a company because of one. So I do not want to go into this in detail because I think most of the seniors know which companies have these problems. Troponin, absolutely essential. Tropti, tropi. Tropti you have to look at the renal impairment which can interfere. Tropi, absolutely clear. But it does not answer only a myocardial infarction. It answers myositis. It answers a lot of things regarding the cardiac muscle. There is a special paper by Alan Jaffe, a leading cardiologist, who gives you the 10 commandments of troponin. And it is absolutely amazing what all cardiac manifestations can be reflected in troponin or the NT-proBNP. And that I think all seniors in the lab should read. Another special protein is serum light chains, kappa and lambda, done on many platforms. And there are certain platforms which have specialized and international fame for this. They are very sensitive and they give you a reading called prozone. And when you dilute, it is a figure that is absolutely horrendous. But you speak to a clinician and he says, yes, the patient has had a bad relapse. So we have to understand what we are doing, not by a platform, just put a sample on the machine. There are challenges at every phase of our lives in the lab, 24/7, 365 into 50 years you work in the lab. It is not a one-day solution. But the more we seniors understand what we are dealing with, and nowadays we have a lot of literature at our fingertips, we have a lot of help from the companies who can solve many of our queries, etc., and our peers who help us. I think this is the way lab should go forward. Body fluid specimens are usually neglected. What is that? You do glucose, you do protein, and then if they ask you do ADA. ADA is a problem. ADA is an absolute problem. When are you drawing the sample? How long is it standing in your lab? Who is doing it? How is it done? What is the calculation? What are the interferences? Where can you get high ADA other than POTS? This is something that has got to be understood. And this article gives you a fantastic review of what you can look into in fluids. Drug assays. Patient on tacrolimus. Children, adults. Renal transplant and other transplants, liver transplant. What was the last drug? What was the assay? Patients sometimes, and doctors also feel, are you asking us because you want to work on that accordingly? No, it's not that. The lab will know if it is going wrong. If the patient has been taking a high dose and we are giving something that is not related to that, then I think either we are going wrong or the patient has not taken the medication. This is a typical example in prothrombin time. We do a lot of prothrombin times during the day. And you will find that sometimes the patient is taking 4 mg and then he says his INR is only 0.9. And then you keep asking them, they've come from rural area, and you say, have you taken? No, no, no. Finally, after spending 20 minutes with them, he'll say, yes, yes, I did not take yesterday or day before yesterday because I did not have the medicine. I was coming to the hospital and I was in the train, etc., etc. And there you have your answer. So interacting with patients, which may not be feasible all the time in all types of labs, I accept. But the thought process, if it is there, can solve many problems. Is the patient on heparin? What type of anticoagulant? There are certain anticoagulants, especially the latest platelet inhibitors, which interfere with a lot of tests. Then what does this mean? This means clinical correlation. We have to insist on clinical history and communicate with the doctors. The nursing staff sometimes are very useful to communicate with, but finally you can talk to the doctor if one has a doubt. So what do I say? My time is getting over. I didn't think it will finish so fast, but it's getting over. Identification of patient and specimen is absolutely essential. What does it mean? We are looking at 3 analyticals. Analytical understanding. What is it that our particular instrument can read? Our particular instrument is not perfect in all the 100 parameters we do. It is maybe 95% perfect in all the parameters, but there are still 5 parameters which we are doing, which other hospital platforms can do better and give a better picture. We have to understand that. Quality management, nothing comes with understanding interferences if our quality management processes, as explained yesterday, are not clear. Sample acceptability and rejection criteria. This is very, very, very critical. We in our lab, we never return a sample that is rejected. You may ask me why. If I return a citrate tube, which is underfill or overfill, they will draw to say 0.5 ml, which is overfill or underfill, and put it into this. Damage is done. They have collected sample in EDTA, and then the sister realizes I have not put in citrate tube, so she'll pour this, and then you get a prolonged PT. So these are things which are very common, and I think each lab sees it. And the top brass of the lab is absolutely responsible for monitoring these things and therefore challenging all the interferences that come with it. Appropriate test requests, absolutely essential. Because if the request with the clinical diagnosis is there, we have a way to repeat a sample by ourselves or ask for a fresh repeatable sample, which means interaction again. And we can also suggest reflex testing, which helps the lab grow in its sphere and respect that this lab knows what it's doing. And last but not least, keep communicating with the clinician and your peer group labs. And that is how we learn laboratory medicine and its challenges. Thank you very much.